We have made it into something supposedly quite simple. It's a calorie balance, issue. That's certainly part of it. What we don't know is that, black box in the middle, right? Like what's going on in there for individual people. There's data to show that patients with obesity, because of this sort of blame and shame that has been propagated for years, that people with obesity feel like they don't feel welcome at their doctor's office. The long-term vision of obesity care is really that it will be delivered in your primary care medical home eventually.
Welcome to Keep IT Healthy podcast, the show hosted by people making things happen in technology, aiming to optimize healthcare delivery, health, well-being, and fitness. My name is Jan Kamiński, and I'm the co-founder of a company dedicated to improving the quality of life with IT solutions and digital advisory. We started making this podcast to amplify great thinking to propel healthcare forward. Today, I'm thrilled to have Dr. Angela Fitch joining us. Angela is a Chief Medical Officer at knownwell, an Assistant Professor at Harvard Medical School, and a member of the Obesity Medicine Association. With extensive experience in obesity medicine and a passion for innovative healthcare solutions, Angela brings a wealth of knowledge to our conversation. Stay tuned as we explore Angela's journey, delve into the dynamic challenges of obesity medicine and healthcare innovation, and discuss the future directions of the industry. Welcome, Angela.
People tend to get treatment for their disease of obesity and then not, and then regain weight, and then, need to go back and try to lose weight again. And that's, what studies have shown is that that's not the most successful way to do it. Hopefully, we can lose weight and try to keep it off long term. And that's going to be much more health beneficial for us in the long run if we do that. So that's what we're trying to do at knownwell. We opened our clinic. We do both virtual and in-person care. So we're a hybrid model. And we opened a clinic here outside of Boston, Massachusetts. And then we're opening next week, actually, in Dallas, Texas. So we'll have those locations. And then, at the start of the year, we're going to open in New York City and Atlanta, as well as Chicago and some other areas, in the next couple of years. So we're hoping to expand the access to care for people with obesity.
You started out as a doctor, and why did you pick this specialization? So obesity, as mentioned.
Well, it really came out of, my patients, when I was doing primary care, people would come in and they would say, well, how do I lose weight? How do I make this better? And as a physician, we don't get much training in that. And unfortunately, despite the fact that our metabolism has been around for centuries, right? Like this is something that we've, it's not something new to the human body, right? But we haven't spent as much effort in medicine in terms of understanding human metabolism and how it works. And I think, being an engineer, which are, generally people that like to solve problems and figure out how things work, it always fascinated me, that it's more than just calories in and calories out, right? It's not just a black box in the middle, like the calories come in and the calories go out, and then, you have the stuff in the middle. And so, I always was just fascinated by that. And I think, as we started to treat patients with diabetes a little differently, we, with the advent of GLP-1 therapy, really, which was when I started in my primary care journey. So in, 2001, 2002, 2003, that time frame was when the first GLP-1 agents were created and produced for diabetes, for type 2 diabetes. And in seeing how amazing they helped patients, to be able to manage this disease state, both type 2 diabetes, but also, weight management, right? And eating behavior, and, seeing all the positive benefits, it just really fascinated me. So I think that was one thing that kind of, triggered it all. And then my family has had struggles with obesity, themselves. And so it was always something that, was kind of, I think when it affects you personally, that's when also you sort of say, hey, this is something that's affecting my family, and, why has no one, tried to fix it, right? Or tried to make it better. And so that was, I think, another driver as well.
Why do you think this disease, why it grows so fast, and why this problem is getting bigger and bigger, even though the technology is advancing and we're developing? What's the main reason for that, in your opinion?
Well, I think it's extremely complex, right? And that's the thing that we've overlooked for decades, is that the complexity of it all. Like we have made it into something, supposedly quite simple. Again, just eat less and exercise more, right? It's a calorie balance, issue, which we know that it is. That's certainly part of it. But what we don't know is that, black box in the middle, right? Like what's going on in there for individual people. And we know a lot, for example, about cancer care because we've done a lot of research over the years, around cancer to the point now where we can, do molecular testing. We can, figure out what's going to be the precise best treatment for a patient, based on some of their cancer characteristics. And we really need that same sort of research to develop for obesity because we've marginalized it so much, right? We've put it into this category of just the fault of human behavior. And when really it's not just the fault of human behavior, right? And the fact of the matter is, our metabolism and our weight is controlled primarily by our hypothalamus, which is an area of our brain that we don't have control over as humans. We can't control our hypothalamus. And so, the fact that this is something that's so, tightly regulated biologically, and then overlay that with what's happening in the environment around us, right? The increase in sedentary behavior, the more jobs, we have in front of a computer now, the more, decrease in walking or, traveling by motor vehicles, et cetera. There's just a lot of issues in the world around us, even the lack of focus on sleep. We're up late at night, either watching TV or, I remember back when I was little, you couldn't watch TV past like 12 o'clock at night, 1 o'clock in the morning, because the TV would just go blank. I mean, believe it or not, there was like nothing on. It would just be like, like a bunch of jaggedy lines. I mean, I remember having like slumber parties with my, fellow classmates, and we'd have to just go to bed, at midnight because like there was nothing else to do, right? And so I think that, we don't even have that sort of focus on our sleep. So all of these, we know that all of these things play a role, and stress, in our environment as well plays a role. So it's not really one thing versus another, right? I think, we've also, developed a world of nutrition that is, mostly made up of ultra processed food. And I think we just never thought about, how that would affect us as humans, right? That interaction between some of the things that are in these processed foods and our bodies, we just didn't think anything of it, right? And not much like, we regulate our drugs, quite heavily, right? We make people do randomized controlled trials, and we make people, prove that it's good for you versus bad for you, but we don't do the same, as it relates to our food environment. And so, who knows what that's, done, over the years. But I do think that it's not one thing, right? We can't just change, the people that get up and say, oh, people just need to eat better, they just need to move more. That's not going to solve the problem. And we've shown that for years. So we need to figure out, a better way forward that's going to help, to really change this issue.
Why, by the way? Why do you think a healthier diet and more activities won't help in the long term? Or what do you mean by that?
Well, it hasn't so far, right? We've tried that for decades, tried to encourage people. It's not, it's very challenging to live opposite your environment, right? Like the environment that you're put in as a creature, when we study creatures in their environments, right? People go out and they study animals living in their native habitat, right? Animals don't live opposite of their native habitat, right? They live into their native habitat. And so to ask us as animals, as creatures, to live opposite of our native habitat is very challenging, especially when some of the drivers of your behavior are not under your control, under your executive control. And so, that's just the extreme challenge of what we're dealing with, and what we're seeing, with some of our treatments of obesity is that, the treatment actually helps patients to have more control, right? Because these treatments are affecting that hypothalamus, that appetite center of our brain, such that then we can make different choices. They actually help people make different choices. When you're taking some of these medications, not just GLP-1s, but other medications for obesity as well, you're sitting there at the counter of the coffee shop, and you see all of the treats and all the croissants and all the things, and then maybe you see the hard-boiled eggs, sitting there too. And you're just like, I think I kind of want a hard-boiled egg, right? And, there's a difference in choices that are made by modulating inherently this area of our brains that deal with our metabolism. And we just have to, recognize that this is such a complex disease. And it's also not one disease. we have data to show, for example, that, in treatment of obesity, that people behave differently, that their disease behaves differently in different people. So, it's really what we talk about is obesities instead of obesity, meaning with a plural, because it's much like cancer. Like, we don't treat all cancers with the same chemotherapy, right? There was one day when we probably did, because we only had one chemotherapy, I'm sure, at one point in time. But we have figured out over the years that these, cancers respond better to this treatment, and we had to do massive clinical trials. I mean, I remember in my day, in the cancer ward at the Children's Hospital, we would have this whole row of binders. Like, I mean, this was back before the days of a lot of computer, technology, right? They would literally have these binders of papers. They were all clinical trials, right? That were going on with different types of treatment in order to, figure out, what treatment's going to work best, for what patient. And so, that's what we need to get to as far as this disease state goes. And we spent too much time, unfortunately, just saying that it's patient's fault. It's the patient's fault that they're like this. They just need to do better. And we gotta get past that. We have to stop that. And we have to, we wouldn't say that about cancer, I'm sure there was some day when we said it about cancer, that, well, it's just your fault that you smoked too much, that you got cancer. But then we realized that it's not just smoking that increases your risk, and there's other things, and people get cancer for other reasons, even though they didn't smoke. And so we have to really, recognize this as a complex disease state that it is, and get some research going around, who's going to be treated best with what therapy or prevention, for that matter.
As a chief medical officer at knownwell, what is I get the primary mission of the organization, but how does it differentiate from other healthcare institutions, healthcare clinics, or on the healthcare landscape? You mentioned there is also this mental support. What's the USP?
Yeah, well, we really want to be the patient-centered medical home for people with obesity. So there's data to show that patients with obesity, because of this sort of blame and shame that has been propagated for years, that people with obesity feel like they don't feel welcome at their doctor's office, right? That when they walk in, if you can imagine, the first thing you're asked to do is get on a scale that measures your weight and tells you over and over again, year over year, that you're just not good enough, that you should just try harder, that if you tried harder, you wouldn't have this problem. And you do that over and over again, and that becomes very defeating, right? And then you don't want to do it anymore because when you come in, it's the first thing we make people do when we come into the office. We meet them, the medical assistant greets them and says, "Hey, come over here, let's get your weight," And so, we're really trying to be the patient-centered medical home for people with obesity, to make sure they understand that we're here for the overall holistic care of the patient. And we want to do that longitudinally, because so often in this disease state, patients are forced to, in the United States at least, obesity as a disease isn't covered by insurance as a standard benefit. So, it's not a standard covered disease, unfortunately. It was carved out of our insurance policies long ago because it was thought to be cosmetic, and it was thought to be something that people were just doing, back when we had 10 to 15% obesity rates in the 1950s, 60s, 70s, it was thought that if you wanted to lose weight, it was just because you wanted to be vain, you wanted to look better. But now that we've recognized this is a true disease that leads to other diseases, but yet at the same time, we've recognized that we haven't included it as a standard benefit on insurance. So because of that, patients have been forced to get their care in these episodic fashions at different places, right? That are mostly commercial, they're mostly on the commercial market, and not sort of living within the true healthcare sector covered by insurance. And that's what we're going to do is we take insurance. We don't charge you extra fees, to come to us. We have a clinical care team that is there for you to manage your disease of obesity, but also manage everything else that you have to do with your life. Our equipment is specially, made for people of larger bodies that live in larger bodies. So you don't have to feel embarrassed by the fact that the gown doesn't fit you. Patients will tell you they'll go to the doctor's office and they'll be given a gown that is like, tiny, right? And that's very, defeating as well, or embarrassing to be given something that doesn't fit you. So, we're really sort of building the patient-centered medical home for people with obesity. And we're doing that, down to age 12 as well. So, we take care of patients and adolescents that have obesity as well, because again, we want to show that we can take care of you, throughout your lifetime, and not just be there for you, when you can pay for it.
You mentioned the change in the treatments, and obesity medicine has seen as well a significant advancements, especially recently. How has your approach to treating obesity evolved over the years, and what's the role that you see for medications like, for instance, Ozempic playing in the future?
We've had, medications and treatments for obesity for quite some time. The Obesity Medicine Association, which you mentioned, I was the president last year, so the past president of that organization this year. And we've been around as an organization we're an organization that supports the clinicians who treat obesity. So anybody who helps patients to treat obesity can belong to our association for support, for education, for advocacy. That's, why we're there. And our association started in 1950, 1950, when there was 10, 15% of people, the population in the United States that had obesity. So, we were working to treat this disease state back then. Now, back then, we basically had dietary ways of doing it, right? Specialized dietary, what I call prescriptive nutritional intervention. Today, people will think of that as things like the ketogenic lifestyle or using meal replacements. So a very low calorie diet, much like they're doing with the direct trials in the UK, where they're offering these types of prescriptive nutritional interventions to patients to reverse type 2 diabetes and also to, treat weight management. So there are these, specialized ways that we've developed for years using meal replacements, using lower carbohydrate, protein sparing modified fast. There are these specialized sort of dietary ways of helping patients. They're just very hard to live into typically without extreme discipline for patients, right? And not everybody can have that extreme discipline, especially as I mentioned, when we're asking you to live completely 180 degrees opposite of your environment that's around you, that's very hard to do, right? And so then we developed, then we had medications for obesity as well, some of which unfortunately developed, side effects or problems that were not compatible with health benefits, right? So they were taken off the market. And so over that course of that journey over the past 75 years, really, right? We're going to celebrate our 75th anniversary next year, has been the advent of better and better medication treatments. We've always had surgery. Bariatric surgery has been around for a long time. It's always been the sort of the most effective or the highest intervention for obesity, right? And much like now, what's coming about is much more like what you would liken to cancer treatment, where it's a combination of therapies, right, over the course of a patient's lifetime: surgery, medication, lifestyle intervention, like you mentioned, behavioral, psychological support. The whole package has to be movement, increase in trying to work on, being more physically active. It's this whole package that is really helping people, to do better and better, over the course of the past 75 years. So I think, our newer medications are just so much more effective. So the issue is the older medications, for example, about 15% of patients taking older medications were able to lose 20% of their weight. So 15% of people could lose 20% of their weight with our older medications. With our newer medications, GLP-1s, semaglutide being the first of that, Ozempic, Wegovy, being the first of that class of more highly effective medications, right? Now you're talking about close to 40% of people are able to lose 20% of their weight. And with our newest medication, tirzepatide, which activates two of our biological hormones that control our metabolism, right? Semaglutide or Ozempic activates one of our GLP-1, right, which is one incretin hormone that regulates our metabolism. Tirzepatide activates two of those hormones now, GLP-1 and GIP. And now tirzepatide, 60% of people are able to lose 20% of their weight. So we went from 15% of people to 40% of people to 60% of people, right, being able to get into that 20% weight loss category. And that's what's really been game changing, right? When you go from 15% of people getting treatment, losing 20%, it's not very noticeable, right? I mean, those 15% are happy, but the other 85% are not so happy that they didn't get that 20% weight loss, right? And 20% weight loss, you think of as not that big a deal, meaning we should, people think they can lose 20%, in a few months doing some sort of lifestyle intervention, right? The other issue is that we have a societal misperception of the body's ability to lose weight. Like patients will be 300 pounds and they come in and say, I want to weigh 150 pounds. That's a 50% weight loss. We don't have any therapies that actually produce that on a regular basis. But yet people think it's reality. Like, but at the same time, you wouldn't come into me in the office and be like, I want to transplant my face, right? I mean, we just don't have that. I mean, we're coming about that. We've seen some of these, futuristic things where people have had that done for different reasons. But the point is that, people would think that was crazy and unrealistic. If I said, oh, let's just go get a face transplant, they'd be like, oh, like that's crazy, right? The average person would be like, that's insane. Nobody does that, right? But people have this misperception of the body's ability to, be to lose greater than 20% of its weight. And it turns out that 20% is where it gets really hard to get past that, no matter what your top weight is, right? That 20% of that weight is where the human body really, really tries to protect itself from weight loss, because weight loss isn't normal for us to do. It's not a normal feature of the human body. And so, adding these treatments that are getting more and more effective is what we see in a lot of different disease states, right? And we're just seeing it now with obesity.
And with your organization, with knownwell, I mean, I know you emphasize innovative healthcare solutions. So how are you leveraging technology to improve your patient outcomes, and what developments are on those, on that horizon?
Well, we actually acquired a company called Alfie, and they were focused on artificial intelligence in the treatment of obesity. And so our head of analytics, Alexander Singh, who created Alfie, has created essentially a obesity large language model specific to obesity, to be able to, take patient data and be able to sort of, in the hope is for the future that we will be able to take some of that data and then help predict what's going to be the best treatment for patients, right? So, over the course of years, we've had a lot of studies, a lot of data, and being able to put that into this large language model that then can help, to more personalize the care for patients. I think in the future will be, where both patients will get more benefit from that. Right now, it's really a trial and error process for us, right? We have to just I have to spend, 40 to 60 minutes talking with you, figuring out sort of, what are your sort of issues at hand? What are you dealing with? What's going to be the best treatment for you? And hopefully, with some computer technology, we'll be able to, do that more efficiently, right? So that patients can feel that they're getting sort of the most effective treatment for them right out the gate. And hopefully that'll, help to also scale the treatment, because that's one of the biggest issues is we have 140 million people in America that struggle with the disease of obesity. And we have a, shortage of doctors. And so, being able to treat patients more effectively in a comprehensive manner, but also make sure that they feel cared for and don't feel rushed, through the process is going to be key. So that's one way. We're also using some artificial intelligence in behavioral change. There are some newer apps that one of the apps that we're using is called RX Food, and it allows you to track what you're eating, using pictures and artificial intelligence to analyze those pictures, and therefore be able to sort of help our dietitians, to help people transition their nutrition plan, to the best of their abilities, for their patients. So, being able to know that, maybe I'm not eating enough protein, right, throughout the day, and being able to help me try to figure out ways of doing that, because, as we all hate to track things like, punch in, data in, into our phones or track something on a piece of paper. So being able to just take a picture of it, right, and go through your day is certainly a little bit more, more
Easier.
user friendly. Yeah. And then gives us better data, gives us more discrete data. I mean, in the past, the dietitian would have to sort of analyze all that and spend some time, looking over, what you were tracking, right? And now, the artificial intelligence kind of, will do it for us. And then being able to just, see patients virtually is definitely a benefit, right? So patients don't have to travel to the office. They can be seen on the computer like this and get the same level of care that they would if we were sitting together in the office. So being able to do some of that, as well as remote patient monitoring, people can have scales, blood pressure cuffs, glucose monitors that they have at home that connect to our platform, so we can see that data again, depending on the patient's needs and their desires, right? And for a lot of patients, that is helpful, to have that accountability and to have that level of support, right? Because that's what really we need to have if we're going to make some of the changes that have to go along with some of the medications to get the best outcome ultimately. If you take a medication and you just don't eat all day, that's not health. That's not a healthful way to lose weight, right? And we don't want people to starve, so to speak. And that's not good for you nutritionally. It's not, you don't feel well, if you're not getting the right nutrition. So
You're known for the innovative patient portal. Could you explain the key features on the portal and how it enhances the patient experience and patient care?
yeah, so we're actually in the process of developing our own patient portal at the moment. And so again, it will have, right now we're using a pre-built patient portal that comes with our EMR. We're also using an electronic medical record that's a full service electronic medical record. So we think that differentiates us a little bit too from a lot of competition. A lot of people develop their own EMR or their own way of tracking patients, right? They just build their own technology. And what we felt really passionate about is we wanted an electronic medical record that was integratable with other electronic medical records across the country. So, in other words, a lot of these homegrown EMR things don't pull data in from other places. We're capable of, if my patient goes to an ER in New York City, I can see that in my EMR. I can see that, that gets transmitted to me pretty much the same day or that night, right? So I can see that the next day. And when I'm seeing that patient, I can be like, oh, you were in the ER, I see. Well, that's not something, that's going to come into the portal of something that's just homegrown and is your own app. So we're building our app on top of our EMR, and then the two are going to talk to each other. And so I think, that'll be very helpful for this idea of, integrating this into the clinical care of the patient, right? We're talking about doing real clinical medicine, not just doing something that's over here on the side. We want it to integrate with the entire patient journey, across their lifetime. So the app will have things like a movement program built into it. So patients that want support, for, doing their movement program, it'll have dietary information and the ability for a patient to, also from an artificial intelligence standpoint, ask questions like, I'm struggling with constipation, what should I do? And then, that will be able to give patients some basic knowledge, to get started. And if their problem is more acute, right, then be able to level that up, to the next level of chatting with one of us. So again, there's going to be a lot of, ability to help patients, in their journey and help them stay connected, to us in multiple ways.
With that being said, what are the biggest challenges that you've encountered in obesity medicine? It doesn't need to be connected with tech, just in general, like how then knownwell is addressing these challenges differently compared to traditional healthcare providers that are out there.
Yeah, that's a good question. So one of the biggest challenges in the United States is our insurance system having to get what's called a prior authorization on medications, which means, we have to justify why a patient needs a medication, and then we have to fill out paperwork and do all this. So being able to understand, what the requirements are for a patient beforehand, so as we're seeing them, being able to understand that these are the requirements for that patient to be able to get coverage for this level of treatment, et cetera. We're going to be able to we have some insight into that via our technology that we're partnering with some of our other technology partners, in this space. So, and then also just doing that prior authorization, we've created a very specialized prior authorization team to be able to do this sort of work on the backside, right, to get that work done. And then you also have to, for this prior authorization team, they have to understand when, they've submitted data, the insurance will come back and say it's not approved, but actually it should have been approved. So there's a lot of that happening in the United States, unfortunately. So even though the patient, checks all the boxes, by the requirements, sometimes the insurance will deny that, even though, you've told the insurance that, hey, this patient has already done that. So, our team is trained in how to recognize that and then, resubmit that prior authorization, to sort of push back and argue, if you will, or appeal to the insurance. So being able to do this second order of treatment, is what's unfortunately needed. And, all that work unfortunately is uncompensated, meaning we don't get paid by the insurance company to do that work. So all those people, the technology, all the stuff that's, going towards that work is something, that isn't something that's reimbursed for. So, but setting this up really helps our patients, right, to get the ultimate best outcome. And then our hope is that in the future, we'll be able to deliver this care in a value-based care fashion, where, for example, you could envision that an insurance would pay a bundle and, they would pay for the service in a bundled payment, versus this sort of, nickel and diming, so that we can, provide this holistic care for patients across their lifespan, with a little bit more value added feature.
And you mentioned some technology partners. Probably you work with some, and they're more not only from connected with technology. And obviously, collaboration is crucial in the innovation, especially healthcare innovation. So, are there any key partnerships or collaborations that knownwell is involved in and that are driving significant progress in obesity medicine?
Yeah, we're working with, first of all, I think one of the greatest inventions of all time, at least in my 25-year career, and I wish it would have come a little bit sooner, is the ability for artificial intelligence to do our documentation. So, I mean, for years, I have been, relegated as a physician with, a high level of training, a doctorate of medicine, and I've been relegated to a typist, right? And like how many patients you can see was dependent on either how fast you typed or was dependent on that you didn't type at all, which is the negative aspect, which is that you typed very little and then people couldn't figure out what you did. So now that we have artificial intelligence for these types of processes, it really does help on the other side of things, which is equally important, right? Which is clinician burnout, right? Preventing clinician burnout is huge. I mean, it's why we have a shortage in the United States, just, so much work effort put towards us, so much negativity, meaning not being able to get the care you want to get for your patients. It's really, considered to be, somewhat of a moral injury today, meaning morally you want to deliver this care to your patients, but yet people are telling you, no, 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 all the time, you can't do that. Even though it's the best treatment, that's morally challenging, right? It's injurious, and helping clinicians to do their jobs more effectively. We're working with NABLA, which is a company out of France, and partnering with them to really, get them integrated into Athena, which is the EMR that we use, which is a large EMR here in the United States. There's Epic, there's Athena, it's pretty much, and then it goes from there. But we've been partnering with NABLA, and really, I think it's just the future is going to be there, right? That I can just say, in our visit, I can, you can ask me for a letter for work, and I can say, sure, Jan, I'll write you a letter for work that you can go back to work next week, and you don't have any restrictions. And then the computer just picks that up and writes that letter. In the world today, I have to go into a separate section of the chart, the letter chart. I have to click on a button. I have to pull up a letter. I have to, type in or dictate in what I want to have in that letter. I can have some standard letters potentially, right, that are pre-saved for me. But still, I have to create all these processes, all these steps that shouldn't need to be created by me, right? If I say that during the visit, some technology should do that. Same with ordering, right? We're working on, verbal ordering ability. So not only just dictating the whole note, which is just the interaction between us, like what we're talking about, but actually then the next level is going to be, when I say, oh, Jan, we're going to start you on Ozempic, 0.25 milligrams, you're going to do that for 4 weeks. And then you're going to increase the dose to zero point 0.5 in the next 4 weeks. I'm going to order that for you. And then I'm going to order one refill. And it'll be able to pull up that order, for that prescription. So I can then, look at it, make sure it's correct, and send it off to the pharmacy. So, I think a lot of this is really going to change, not only patient care, but also, help to protect us from, having a bunch of doctors that quit medicine. So that's one of our partners.
And what about the long-term vision? And especially in the field of obesity medicine, where do you see that there is the biggest opportunity on this market? What are your thoughts on that?
Yeah, I think, the long-term vision of obesity care is really that it will be delivered in your primary care medical home eventually, Right now, it's not because clinicians aren't set up to do that. They're not trained to do it. They don't really understand it, but they're more and more becoming, understanding it more and more. And as we develop these systems that are going to make it easier, one of the other tech companies we're working with is called Prescriber Point. Again, for a clinician to understand what a patient has coverage for beforehand, also understand like where that drug is available at the pharmacy, right? So you don't have to send it to 12 different pharmacies for the patient. I mean, that's a little bit ridiculous in today's world that, when you want to go to a different pharmacy, you, Jan, have to like tell me to send it to a different pharmacy. I mean, that's just, ludicrous in today's technology world, but that's what realistically happens. So that's a lot of work effort. So I think, the future with all this technology will allow us to work more efficiently so that then we can provide better holistic care. I can focus on taking care of you, not focus on the administrative work that I have to do in the chart, which currently is probably taking up, 60% of my time. And so as we're able to provide this better care, I think it will transition into primary care, right? Because primary care takes care of a lot of diseases, depression, anxiety, diabetes, hypertension. And then when those diseases are too complicated, they level it up to a specialist. And there will still be a need for obesity medicine specialists for sure, because there are 140 million people with obesity. We're only treating, data shows we're only treating about 2% of those patients today. So the more that we get this out there, the more our patients might get on a medication, for example, that's, maybe not the newest, latest, and greatest medication, but one of the older medications today, just because of cost and access. Even if they were on those medications and were able to lose 10% of their weight, that would be a huge accomplishment, right? And we have to get more treatment, more of this sort of basic treatment out to more patients. And then, also figure out how to, leverage this newer technology we have for more people. Again, marrying the cost with the access, because, until the cost comes down, which we expect it to come down as more and more players come on the market, but until the cost comes down, we're going to need to figure out a system by which, patients are getting treatment, like which patients are the sickest, right? Or which patients need that treatment the most. Or if a patient doesn't need that treatment, for example, meaning there might be another treatment that's effective for them, they can also choose potentially to pay for that treatment if that's the treatment they want, right? If they want to level up before they, sort of are due, if you will, from an insurance perspective, if they have the means to do that, they could do that, themselves. So again, I think, providing this sort of, we're currently writing the standards of care for obesity treatment in the United States. Once these standards are done in the next couple of years, as they come out, right, they're going to come out in parts, right, over the next year or so. As they come out, it's going to drive that sort of standard development of processes within primary care and other places to deliver this care. And that's why we built knownwell on this basis of primary care, because we recognize the future is not going to be a independent solution, for your obesity. You're not going to go to some obesity clinic necessarily. You're going to get a lot of that care, basic care through your primary care office.
We have a lot of doctors interested in tech listening to us. And as a leader in your field, what advice would you give to aspiring healthcare professionals who are passionate about tackling chronic diseases like obesity?
Exactly. Because there's other chronic diseases, right, that we're not doing a very good job with: diabetes, hypertension, cardiovascular disease, right? So we need this in several different places. This is not just, obesity, right? But I think the more we can develop these technologies that make it more efficient for clinicians to understand what patients' issues are, right? Whether that's, so we call that their phenotype, right? So as we learn to phenotype patients, and then also maybe throw in some of these other, genotype and other types of issues as we progress, being able to understand, what treatment is going to be best for that patient, and then help them to stay adherent to that treatment, right? And that's, I think, the big issue, currently, is that a lot of patients don't understand why it's important to be adherent to treatment, especially with the disease of obesity. There's data to show that if you lose weight and you go off treatment and you gain your weight back, that it's harder to lose the next time. So weight cycling like that is not necessarily good for us. You don't want to do that. You want to lose weight and you want to try to keep it off eternally. And that's going to be the challenge, is measuring those patients over time, right? Like I always had this dream, especially during COVID, I was always like, I can't believe we don't have like the HealthMate 2000 in our home, which I just randomly called it that. But the idea that you have expensive appliances in your home, and these expensive appliances, refrigerator, stove, they tend to come even with your basic apartment. Like, so if you're renting an apartment, you don't have to ask for a refrigerator. You typically have that in there. It's what, $900, $1,200 piece of equipment. I mean, but yet we don't value the fact that we could easily have a scale connected to a blood pressure cuff, connected to a thermometer, connected to a incentive, measure a pulse ox, right? Measuring your oxygen saturation. I mean, it could even potentially do basic labs. I mean, you could have a CGM that connects to it all, right? And then you could be able to deliver that. You could, as a patient, say, I want to send this, I'm seeing Jan today. I need to send this data to Jan, right? And you would get on this machine like every day, right? And it would just sort of like track you, right, over
Right.
time, and be able to predict even when something is going wrong, right? Like when something is going awry. And again, maybe people think of that as big brother, too big brotherish, or too invasive. But I think, we're going to need these levels of technology to be able to move care forward, especially as we're doing more and more virtual care, right? I shouldn't have to ship you this equipment, as part of my clinic. I should be able to, have patients insure, even patients with health equity issues, right? Because again, this HealthMate just comes with the apartment, right? And it's going to be a lot cheaper than a refrigerator, most likely. I mean, so I think the more we can try to invent these things that are going to help populations get better, not just individual humans. It's very much a commercial market for a lot of this tech, right? It's if you want to, engage in it. If we have sort of the patients who are the healthiest, patients who are the wealthiest, that are engaging in some of these tech-enabled services, but we really need to help other people be able to do that at scale, right? So that we can understand what's happening to people, on a day in, day out basis, without being too obtrusive.
Angela, thank you very much for joining us today and sharing your story with us.
Yeah, thank you for having me. It's been a pleasure, and I look forward to a future where, a lot of these chronic diseases, patients don't have to struggle with, right? And that's the hope for the future, as a lot of these things I think will change over time, as we implement better care solutions for people.